So welcome to Grand Rounds, everyone. Just a few housekeeping issues. Since we are changing the way that we obtain CME credits, I'm going to ask Shrella just to give us a very quick update on how that process is going to occur for ongoing.
Yeah, it's super simple. It might seem a little complicated right now, but I promise it will get easier. Every Thursday, or actually every Wednesday before Grand Rounds, you'll get an email from me, as you always do, as a reminder. It will include an activity ID. That activity ID just needs to be texted to this number that's here. And I'll hand you out slips too, because I know we all forget. It'll also be posted on the door. This is how we will track your CME credit as well as evaluate the presentation. So I definitely need you to do this. Everyone will get the same alert saying you're not in the system. I got it this morning as well. Email them your address, text them your email address, and then they'll say, okay, we got you in the system. We have your attendance down. Let's get it going. So it should be easier every time after this one. If you have any questions, please ask me. I have no problem answering questions, okay?
Great. Thank you very much. So we're really happy, honored to kick off this year's Grand Rounds presentations with a presentation by Dr. Vardey. Rocky, as you all know, is a proud graduate of our program here at KU, where he finished his physical medicine and rehabilitation residency. He is done a fantastic job building our inpatient consult service over the last year, and has been very active with not only team building and relationship building with our colleagues throughout the campus, but also in stroke research. So we're really happy to have Dr. Vardey give us a talk on stroke rehabilitation. Thanks, Rocky.
Hey guys, so in kind of thinking about what I really wanted to talk to everybody about, it really came down to consistently just thoughts of stroke and all the new research out. It's impossible to put a presentation together to talk about, clinical and primary rehabilitation research, but I lucked out a little bit because in the last month and a half, we've actually had month and a half, 2 months, we've had some great recommendations come from the American Heart, American Stroke Association, and the panel has done the job for me, coming out with the new consensus. So I wanted to kind of go do an overview. Not all of us have time to read through 70 pages of recommendations from a panel somewhere else, telling us what we really should be doing in rehabilitation. Some of it really just reemphasizes things that we've already done, and some of it are things that we never really thought of that there'd be as much evidence out supporting. So I apologize if this is too intuitive for some of you, and it's just a brief overview and just excerpts that I thought was really important for us to know. And I actually go through a few different points here as well. So without further delay, so I had no conflicts of interest or financial disclosures. Does everybody understand?
Riddle me this, riddle me that. Who's afraid of the big black cat?
And I hate to pick on our residents every single time, but let's start with somebody, and I don't want you to give your answer just yet. I want you to really think about it. And as we get towards the end, we'll actually pick on you a little bit more as well. So why don't we start with Dr. Vardey, the guy I like here. Very early mobilization after admission for stroke was shown to be potentially detrimental to long-term recovery. What do you think? Is that true or false? Very good. We will come back to that in a bit here. This is one that we've actually gone through many times in my service, talking about the outcomes. How about, who else? We have PGY2s in the audience here. There we go. I1A. What medication with an original indication for depression has been recently studied in the RCT, showing promise for motor recovery in moderate to severe stroke? And we'll get to that one as well. So, The objectives I really found were going to be important for us today is to be able to recall the impact of stroke on the individual and society. It's a reminder to all of us, what stroke really means to society, especially when they haven't had a stroke. How important is this financially, an impact in terms of disability, and what is society, having to think about for all of our futures, especially when we understand that stroke is such a big impact on our lives. Also, to be able to cite and review evidence-based consensus recommendations provided, like I mentioned, by the American Heart Association, American Stroke Association guidelines for stroke rehabilitation, and to discuss the benefit of a coordinated multidisciplinary team in stroke rehabilitation in general, as well as discuss additional studies pertinent to stroke rehabilitation. And these studies that I'll discuss here today are not, groundbreaking by any means, and things will never be the same because of these studies. These are studies that I plucked out that I felt like we use in our everyday life practice, and I find it very important in academics for us to understand. And all actually from the last just few years is recently why I wanted to choose those. Just evidence and clues, and that's where the Inspector Gadget thing came from. Per the NIH, evidence-based medicine is defined as the conscientious, explicit, judicious, and reasonable use of modern, best evidence in making decisions about the care of individual patients. It integrates the clinical experience and patient values with the best available research information. Now, we really use this as a broad term, but it's often helpful to take a second to look back and say, what are we really? Why are we so fervent, especially in academic centers, of using our evidence? And does it always just mean like the most pristine randomized controlled trial, or are we using some consensus, best practice from what we've been using for years that is just the standard of practice at this point? Sorry. So the institution of the ACA and changes in Medicare reimbursement are going to emphasize the need for quality of care and outcomes over quantity of patients and services provided. And that's really the definition of value, outcomes per dollar spent in healthcare, and it's increasingly being emphasized in the world around us. And this isn't just for, we'll talk about this, endlessly in practice, especially in the private world. In the academic world, it's important for all of us to start thinking about the future of medicine. And so we're teaching our residents and teaching folks around us that this is going to be, the emphasis in the near future and probably in the far future. So I'll quote Dr. Mitra here and an article that he had just put out. The acute inpatient rehabilitation has been shown in multiple patient populations to result in shorter lengths of stay, lower readmission rates, and or improved functional outcomes when compared to skilled nursing facility. So the real question becomes, in the pursuit of best practice, where is stroke rehabilitation? Are we holding true to these best practice and evidence-based features to really emphasize the quality of management rather than just, simply numbers? So by the numbers. Stroke by the numbers in general, it remains a major healthcare problem with a staggering human and economic toll. For many of you on who are working on my service, this is I'd say a vast majority of the patients we see. You realize day in, day out, we have patients that are coming from other facilities, that are patients that are coming directly to our facility because of our expertise, and it has a huge toll both on their micro communities as well as the macro community in general, in the U.S. and in the world. Approximately 795,000 people in the United States have a stroke each year, of which about 610,000 are first attack, and 1 in 4 are recurrent strokes. These are folks that are having their primary stroke on our rehab unit, extension thereafter, or having some sort of second event, And we all understand how those are even more impacting on everyone's lives. On average, every 40 seconds, someone in the United States has a stroke, and I really like to think about that very, very clearly, especially when you're thinking every 40 seconds in the U.S., and we are a primary or a comprehensive stroke center here. So we are seeing many of these folks. So approximately 6.4 million Americans are stroke survivors, and the fourth leading cause of death in the nation behind heart disease, cancer, and chronic respiratory disease, according to CDC from the 2010, which is the most recent available. So, and from a perspective of our role as physiatrists and as rehabilitation specialists and folks in the research realm as well as the practice realm and therapists, it's really important to see that this is the bulk of our population. This is just, these are the folks that we're seeing day in, day out. Stroke kills 130,000 Americans each year, which is 1 in every 19 deaths. And this is a staggering number. Stroke costs approximately $38.6 billion each year. That includes costs of healthcare, services, medications, and missed work days. I think it's very difficult to move past that very quickly, just because we understand that that's an impact on all of us, on society. And as we think about the ACA and we think about the lack of expansion of Medicaid and all those types of things, you start thinking about where this money's come from. And just as an example, I had a patient that came into my clinic yesterday, and we spent a great deal of time just talking about how significantly it's impacted their lives from originally having an income of $8,000 per month, and now not being able to work, and now having $1,000 to $2,000 per month to really live off of. And that's those times are really moving to me to think about how significant changes they'll have to make in their lives, and not only lifestyle but just overall functioning and support systems and all those things. Stroke is obviously a leading cause of functional impairments. About 20% of survivors require institutional care after 3 months, and about 15 to 30% are permanently disabled. So I thought we'd get right to the next. Bottom line is it's dry enough while we're reading it, and I'm trying not to make it any drier, but it's going to be somewhat. And so I want to emphasize the big points that, as I'm going through guidelines to review for this presentation, that I felt like I really took, and that can help us in practice every single day, whether it be doing, seeing a new consult over the weekend and giving recommendations that are evidence-based, seeing a new consult with me, and I'm emphasizing on different patients, different things. It's really helpful to kind of extract these things, and I can give you all, maybe after the presentation, if anyone ever has any questions, I can give you references of where some of these things are kind of extracted from this presentation. Sorry. So this is published as the guidelines for adult stroke rehabilitation recovery and stroke magazine, stroke journal on May 12, 2016 as a guideline for health professionals from the American Heart Association and American Stroke Association. And it's endorsed by the AAPMR and American Society of Neurorehabilitation, as well as the American Academy of Neurologists and many other academies, which I won't go too far into. But I think it's really important to understand that these guidelines were actually put together by both rehabilitation specialists with doctorates in physical therapy, as well as physiatrists, as well as neurologists. This is a comprehensive view of, we now know this patient has these impairments and these disabilities. How do we best serve this population? The purpose is to provide a synopsis of best clinical practices and rehabilitation for adults recovering from stroke. It should serve as a standard in all phases of stroke rehabilitation, supporting the role of therapists and therapies, post-acute facilities, nursing, and medical management. And I want to put the emphasis as we go along that the reason I felt like it was a positive thing to go through these standards is we talk about both the medicine side of it as well as the rehabilitation and therapy side of it. So it's several years in the making. These guidelines are really extracting data from the last multiple decades, all the way about, I think the oldest study I saw was about 55 years ago. Thorough review of the evidence, 73 pages, and I'm giving a quick synopsis. It's dense, so here's a quick overview. So first of all, we talk about evidence-based medicine. We almost want to talk about the class and level of evidence. Really, how good a quality of evidence do we have over what we're talking about? So class 1 is for conditions in which there's evidence for and our general agreement that the treatment is useful and effective. Class 2 is conditions where there's conflicting evidence or divergence of opinion. And 2A is weight in favor, and 2B is really weight in the other direction. While class 3 is really for conditions in which there's evidence that aren't really useful or effective and may actually be harmful instead. And then we talk about the actual therapeutic level of evidence, where A is probably the highest quality of evidence from multiple randomized controlled trials or meta-analyses of multiple randomized controlled trials, as well as data from one trial, as well, and B, it's really data from one trial or several different studies, cohort studies, and retrospective reviews, and C is a consensus opinion of the experts, case studies, and standard of care in general that we've just been using for years and years and just may not have quite as much evidence behind, or it's just very difficult to study, I think. It's a way to put it. I don't really, in my mind, when thinking about this, especially from therapeutic, from a therapeutic perspective, I don't necessarily say that, just because it's level A, that that this area is just a shoe-in, that this is absolutely the way things should be. But I will say that many of the practices that we use have level of evidence, just in our everyday practice with regards to stroke rehabilitation. So diagnostic recommendations, A is data from multiple prospective cohort studies, B is data from one grade A study more than or equal to the case control studies, and C is consensus of expert opinions. So there are many topics that were reviewed, the trends in the use of acute and post-acute rehab in the U.S., rehab interventions in the inpatient hospital setting, and I really emphasize these more than the others, but also prevention and medical management of comorbidities, including skin breakdown, contractures, DVTs, falls, treatment of bowel bladder incontinence, assessment, prevention, treatment of hemiplegic shoulder pain, central pain, post-stroke depression, osteoporosis, as well as generally how are we assessing and measuring these things in terms of ADLs, IADLs, disability, motor impairment, activity and mobility, communication impairment, cognition and memory, sensory impairments, and dysphagia. There are non-drug therapies for cognitive impairment or memory, use of drugs for cognitive impairment and memory, limb apraxia, and cognitive and communicative disorders in terms of treatment of aphasias, speech apraxias, dysarthrias, and aphasias. We tend to think, very, very simply about these things, but there are many treatments out there that many physicians are using, some of them with some evidence and some of them with none. So I think that was especially a point that I found interesting. As well as topics in spasticity, balance and ataxia, mobility and ambulation, upper extremity activities, adaptive equipment, DMEs, orthotics, wheelchairs, motor impairment and recovery, including deconditioning and fitness after a stroke, as well as chronic care management in home and the community. What are we doing for those folks when they leave the hospital? And hearing and visual impairments, and then, like I said, transitions into the community. In terms of the actual evidence for rehab intervention in the inpatient hospital setting, there's class 1 level A evidence that is recommended that early rehabilitation for hospitalized stroke patients be provided in environments with organized interprofessional stroke care. You'll find the same kind of theme over and over again, that these studies have actually shown that a coordinated approach with physical therapy, occupational therapy, speech therapy, nursing, case management. All those inputs, as well as the physician input, are vital, and patients do better. There's legitimate evidence that patients do better when that approach is taken. There's a little bit less evidence that in the inpatient setting, we're talking about patients that have just made it to the 8th floor after their moderate-sized stroke, or just made it to the 9th floor, that stroke survivors receive rehabilitation at intensity commensurate with anticipated benefit and tolerance. Really, it means that you can somewhat gauge the amount of therapy for those patients depending on what they actually need and what they do. And then there is level A, class 3 evidence that high dose, very early mobilization within 24 hours of stroke onset can reduce the odds of favorable outcome at 3 months and is not recommended. So I'll get into that a little bit more here. So therapies in the acute hospital setting, again, is what we're talking about. Multiple studies and meta-analyses in 2009 showed insufficient evidence to support or refute efficacy of routine very early mobilization in stroke. So it wasn't necessarily going to be the worst thing in the world for the patient. It wasn't necessarily going to be the best thing in the world for the patient. But some of these studies used a very early period of 24 hours, some used 36 hours, and some used 48 hours. And then they finally did a randomized controlled trial, and it's called AVERT, a very early rehabilitation trial, with mobilization within 24 hours of the stroke, which actually results in a reduction in the odds of a favorable outcome at 3 months. So Dr. Vardey is correct in that. This is the first randomized controlled trial to show that there's actually detrimental effects. A patient first has a stroke, is somewhat conscious, and you're being very aggressive and you're starting therapies within that first day, and may eventually have a bad outcome. And it's fascinating to find that the studies that were inconclusive in general were actually the ones where the rehab was, in the very early trial, was 48 hours. So it really, it's a different way of thinking, especially in my mind, because I think that we tend to think that earlier the better. Let's start all our interventions. Let's get the patient going. Let's get them mobilized ASAP. And ASAP may not be really the answer, but it's still really controversial, I think, in all our minds, even today. And just to say, the AVERT trial is actually in the last 5 years as well. So moving on to the actual post-stroke rehabilitation and really all of our expertise in that next phase after the patient's discharged from the hospital. So there's class 1, level A evidence that's recommended that stroke patients who are candidates for post-acute rehabilitation receive organized, coordinated interprofessional care. Again, we're seeing the same thing, the same words over and over again. There's a slightly lower level of evidence that is recommended that stroke survivors who qualify and have access to inpatient rehab care receive treatment in an inpatient rehab facility in preference to a SNF. And so we'll get into my thoughts on that in a second here. But organized, community-based, and coordinated interprofessional rehabilitation care is recommended in the outpatient or home-based settings, which with level C, class 1. And ESD services may be reasonable for people with mild to moderate disability. And this is just an extension of rehabilitation. So I think just on this slide, because I don't get into it very well, I think sometimes we'll see patients, late on a Friday or over the weekend, and you see the patient progressing very quickly. The therapists are really anticipating this patient probably will be fine to go home. I think, especially as I've kind of gone through the guidelines, it really reminds me that this is the time in which they're going to regain their function in a very abbreviated, very quick manner. And I think taking advantage of that time in inpatient rehabilitation for somebody at minimal assist is obviously evidence-based, as you see right here. The community-based or home health may not be doing the trick for those folks that are at minimal assist. And I think that's kind of counterintuitive to maybe the way that we think and our therapists think sometimes, because we see such a broad spectrum of patients that are very low level, very high level. So just kind of an extension of this, over and over again, the theme is multidisciplinary, coordinated, organized effort is ideal. Multiple studies in the past are performed to analyze outcomes of stroke rehabilitation at an acute inpatient rehabilitation facility versus skilled. There's inherent confounding or channeling bias which complicate this analysis. So this is where I start thinking, you have studies that show that patients that are going to skilled may not have as good of an outcome, but why is that? And so we start overthinking this and thinking, well, the folks that are going to skilled are typically older, and the evidence does show that. So if you're 85 years old and you have stroke-like deficits in the community hospital, not in our facility with a consult service and expertise of our amazing neurotherapists, but a community hospital, they're 85, it's almost a default these folks go to skilled. And it's hard for me to say that's absolutely wrong, because individual cases are individual cases. But generally speaking, younger, healthier, or more acute onset strokes, especially in ages 50 or younger, almost always go to inpatient rehab. So that's where the bias, what we call channeling bias or inherent confounding biases, come in. Do they have less comorbidities? Are they doing better because they're younger? Are they doing better because they're going to inpatient rehab? It's really kind of up in the air in that sense. The consistency of the findings in favor of inpatient rehab referrals suggests that stroke survivors who qualify for inpatient rehab services should receive this care in preference to skilled based care. This is really important especially for my specific interest in stroke. If we can get them to qualify for acute inpatient rehab, the consensus, despite this level B evidence, is still that we get them to inpatient rehab. And I want to emphasize, this is the first time we've had any sort of consensus recommendations that really showed this to be evidence-based on a large-scale view. So again, just a reminder of the interdisciplinary team approach, stealing this from our departmental slide, but the rehab physician, rehab nursing, psychologist, pharmacist, social worker, dietitian, case managers, and PTOT and speech therapy really all can kind of give their insight, and we get patients to a better function, adapted function, better than many other levels of care. So other important findings as I was reviewing that I felt was really important for us to emphasize were level A evidence. DVT prevention in ischemic stroke, prophylactic subcutaneous heparin should be used for the entire acute rehab stay or until mobility regained, and we all kind of understand that to be true. But there's actually level A evidence that's reasonable to use low molecular weight heparin, specifically over regular heparin to prevent DVTs, and slightly less supported evidence for the actual time frame in which you start Lovenox after an intracranial hemorrhage. I think a lot of the time frames they were using was about 5 days, and some of the studies went out to 2 weeks, and it's hard to say in terms of outcomes with prevention of DVT and actual outcomes of adverse outcomes. There's a consensus on that just yet. In terms of shoulder pain, I thought this was fascinating because it's not something we do in our everyday practice. Botulinum toxin in the acute and subacute periods for severe hypertonicity or a trial neuromodulating pain medications are reasonable in the hemiplegic shoulder. E-stim can also be considered. I think there are times in our shoulder, especially our patients with severe shoulder pain, subluxation, kind of a combination of CRPS and neuropathic pain and musculoskeletal pain. We tend to try. I think we often try gabapentin or a neuromodulator, but we don't often think, should we be going ahead and starting to Botox these patients? There's actually a level B, I believe level B evidence in external rotation at the hemiplegic shoulder within that acute period or subacute period in the rehabilitation phase, especially early on in that rehab setting. And I think it's the protocols that a lot of the studies were showing it or were emphasizing was to leave it extended for at least an hour up to about 4 hours, and it results in better outcomes at the end. So other level A evidence, fall prevention is recommended that patients with stroke be provided formal fall prevention program during hospitalization. It's really important for our hospital, in which we're now setting as a hospital-wide initiative of 0 falls. This is a really important thing in stroke, especially, and I've seen it, personally, where our stroke patients have actually potentially been at risk for a fall and brain injury or further fractures and things like that. Post-stroke depression, and I think the reason I put that in there, the emphasis is that in building programs, especially those of you that are really interested in inpatient care, building programs, this is something that you really want to emphasize. Post-stroke depression, emotional and behavioral state, a therapeutic trial of SSRIs or dextromethorphan quinidine is reasonable for patients with emotional lability or pseudobulbar affect. We don't see quite as much of this, but I think we should really keep vigilant because it's actually one of the highest studies and one of the highest levels of evidence. Also, there's usefulness of routine antidepressants. Usefulness of routine antidepressants for depression is unclear. So basically, willy-nilly starting antidepressants for depression, specifically for depression, and a patient who you know is at risk but may not have symptoms or signs, it's really unclear if that's going to necessarily help their outcomes. Combining pharmacologic and non-pharmacologic treatment for depression is absolutely supported, and SSRIs are common and better tolerated, but no class of antidepressants is necessarily clearly better. And I think that's why we default towards SSRIs, because they're much cleaner in terms of side effect profiles. The other finding with regards to post-stroke osteoporosis, especially in patients with long-term care who've transitioned out of rehab or out of skilled nursing, is prompt evaluation and potential treatment with calcium and vitamin D supplementation. These patients are very much at risk, and I can't tell you how many times we've seen patients who had a recent stroke come in new femur fracture. Dysphagia screening and management. Enteral feeding should be initiated within 7 days of stroke for patients with dysphagia. And that was the big emphasis. Early PEG tubes for folks with dysphagia. I think that's an extension with regards to enteral feeding. There is a class B level for actually when you put the PEG tube in, and very early versus within 7 days. But I think about 5 to 7 days is when most recommend that being done. Non-drug therapies for cognitive memory and impairments, and memory impairment, enriched environments are recommended to increase engagement with cognitive activities, which is kind of a shoo-in, we all understand that, as well as compensatory adaptive strategies, use external and internal, memory logs, smartphones, all those things are really helpful, both in subacute and chronic phase of stroke as well. Hemispatial neglect and inattention. There's repeated interventions like prism adaptation, visual scanning training, optokinetic stimulation, virtual reality, limb activation, mental imagery, and neck vibration all seem to help our patients with neglect, and actually showed level A evidence in that extent. There are folks out there that are using dopaminergic medications, bromocriptine, things like that, really a level C to potentially level B for a lot of those things. So pharmacologic management of hemispatial neglect, which I don't think I've ever personally used, is out there, just not really supported quite as much. Aphasias. Obviously, speech-language therapy is primary for aphasia. Intensive treatments are indicated, but no definitive time. Intensity is clearly better. I think sometimes we start thinking, well, we want to build 3 hours of goals for this patient. Well, they have PT goals, they have speech goals. An hour and a half is not necessarily a speech therapy a day is not necessarily shown to be the shoo-in for patients with aphasia versus 30-minute to an hour session. Supplemental computerized treatment is also helpful, and their speech therapists, I think, often use this as well. Spasticity, botulinum toxin absolutely for upper and lower extremities, oral antispasticity medications, and intrathecal baclofen pump all have a level A evidence, as well as e-stimulation vibration, which may be helpful as well, but more used as adjunct. It hasn't been shown that these things, obviously, as we know, are going to be the primary treatment. Imbalance and ataxia, balance training should be provided, and assistive devices, orthoses, should be prescribed if appropriate, and all those things are studied for years and years and years. Some of the oldest studies that we know of for both imbalance and as well as mobility and gait with regards to foot drop for AFOs. Intensive, repetitive mobility training is emphasized, especially throughout this. And I thought this was a really important thing for all of us. The group therapy with circuit training improves walking. Walking endurance was huge. Cardiovascular exercise and strengthening, and actually distance walking was really important for long-term outcomes for folks. I think sometimes we start thinking, well, the patient's walking 50 feet, close to modified independent. That's a problem for my patients who are coming back in suffering either falls or just the inability to really function in their everyday lives. And so I think there's going forth, I'm kind of predicting an emphasis on endurance, or re-emphasis back into endurance in the inpatient and subacute rehabilitation phase. E-stim is reasonable to consider for foot drop, and they actually say oftentimes this is in conjunction with other treatments. And then using a treadmill with body weight supported support can be combined with conventional rehabilitation, and robot mechanical assisted walking are also good. So I want to emphasize this a little bit because we'll actually get back to this. These are all kind of studied separately and then in conjunction with other treatments, and these are all showing level A evidence of this versus placebo, is essentially the way I like to put it. So upper extremity activity functional tasks should be practiced, including ADLs. Constraint-induced movement therapy is reasonable to consider, and I think, again, you say CIMT versus placebo. And mental practice is important for upper extremity function. Bilateral training is helpful. Acupuncture is not recommended for improvement of upper extremity function or ADLs. And that showed an obvious level A evidence as well. Integration and family support, including training, education, home evaluation, organization of therapies at home. So, all right. So I want to go into this recent studies. The recent studies in stroke rehabilitation. One of the recent ones is the EXCITE trial, the extremity constraint-induced therapy, which showed constraint-induced therapy improved upper extremity motor function when initiated within 3 to 9 months post-stroke. Although this was really helpful for us who have been using this for years on end, it didn't necessarily show the level of evidence that this was better than what we've always been doing, and it's interesting. And I think that's why it's important to have rehabilitation specialists and therapists who can really adapt to the patient and what they're best responding to, and to combine therapies. But that was one of the more recent, and I've spent a slide or two on some of these studies. The LEAPS trial, the locomotor experience applied post-stroke trial, involved body weight supported treadmill training. They had just published a study just within the last couple of years, and they were recruiting patients between 2005 and 2012. It was a multi-center, single-blinded rehabilitation study with 3 arms: early locomotor starting within 2 months, late locomotor at 6 months, and then early general home therapy. Really, it's general home therapy is what they're basically using as their standard therapy. So outpatient program for early to late locomotor training, for 36 sessions, 3 times per week, using a body weight support system, stepping on a treadmill. And again, we're talking about within that 2 months, within that later period, and the findings with the specific therapy is helpful, but there's no statistical significant difference from a general functional stroke therapy program led by a PT in the home. And that I thought was fascinating, especially given how much we're emphasizing body weight supported equipment in the inpatient rehab world. This is probably one of the more comprehensive trials, and many other studies have shown many other mixed results. I think the way I approach kind of how to interpret this and what to do with with this therapy that we've been emphasizing so much is that again, we're adapting to the patient and we're saving our therapists backs and using these techniques that do work. We definitely do work, but are not necessarily better than a 4-person approach, a 3-therapist approach. And so I find that, and I also find that patients really respond to this type of program. They actually will be more interactive in that acute period, especially. Another study that that's been coming up in journals, especially lately, is the FLAME trial, and the fluoxetine for motor recovery after acute ischemic stroke. And this is a double-blinded, placebo-controlled trial of 118 patients from 9 centers in France, actually, between March 2005 and June 2009. All had ischemic strokes, ages 18 to 85. They actually used the Fugel-Meyer motor scale. I'm not sure how many of you are really familiar with this, but it's a scale that actually, from a motor standpoint, goes from 0 to 100, and 100 being the highest function, 0 being patients who are not functional. And scores of 55 or less are generally considered to be moderate to severe, or actually moderately severe to severe in terms of stroke severity. And the patients were randomized to fluoxetine 20 milligrams daily versus placebo, starting 5 to 10 days after a stroke, for a total of 90 days treatment. All patients received standard inpatient therapy. Primary outcome was mean change of FMMS between inclusion and day 90. Mean change of FMMS in terms of results from day 0 to 90 was 36.4 for the fluoxetine group and 21.9 for placebo group, with a p-value of 0.003. So there were statistically significant findings that starting fluoxetine and SSRI legitimately does have a significant effect on motor recovery after stroke. The mean day 90 scores, kind of just the other findings, mean day 90 scores comparing groups, as well as mean changes comparing groups in total score, upper limb and lower limb motor specific findings were actually there as well. So in conclusion, in patients with ischemic stroke and moderate to severe motor deficit, early prescription of fluoxetine with physiotherapy enhanced motor recovery after 3 months, modulation of spontaneous brain plasticity by drugs, is a promising pathway for treatment of patients with ischemic stroke and moderate to severe motor deficit. And because this is a trial that Dr. Eichmeier and I emphasize so much, I want to remind our residents of the limitations of the study. There's an unclear therapy regime and controls. And as I'm reading through this article, I think it'd be more helpful to go to an international seminar and talk to some of these folks doing this trial. But physiotherapists were not instructed to design a specific rehab program, but to use a normal protocol for their center. All participants receive standard care delivered by an organized patient stroke care team. That to me is a very significant lack of control and potentially could affect the study and the outcomes. When we're saying all the good things about rehabilitation, then we're saying potentially that rehabilitation could be different from one site to the next. An NIH stroke scale total score did not significantly differ. It may not be important though, but despite the motor and NIHSS being significant. Although that does emphasize to us that potentially this is helping their motor outcomes and not necessarily some of the other outcomes. Others, like exclusion criteria of depression, was fascinating to me. You have a patient who might potentially benefit from being on an SSRI from a depression standpoint, and yet that was an exclusion criteria. There were some other ones. And of course, you need more studies. 110 patients, and standardizing this to, like I said, hundreds of thousands of patients with stroke every single year is a little dangerous, I think. So how do we conclude this? So what do we do from here? What do I want to use, or what do I emphasize for you guys to take from this? These are nice guidelines that serve as a reference for things that we've been doing and things that we may not have been doing in the future. I think it's really important for us to build and extend and improve our practices. And these are continuing emphasis on early rather than very early, of course, mobilization, appropriate intensity and patient-based rehab regimen, safe techniques to prevent morbidity and mortality, and classic stroke therapy interventions. And of course, you're talking about this comprehensive approach, multidisciplinary stroke prevention with via comorbidities and risk factor management, and good follow-up and community support is also very important. Outpatient care. These folks need some support going forward. And of course, more research. So back to this, these, which I guess were very simple questions, because our residents got both of them right. Very early mobilization after admission for stroke was shown to be potentially detrimental to long-term recovery, and the answer is true. And what medication with an original indication for depression has been recently studied in RCT showing promise for motor recovery in moderate to severe stroke? And of course the answer is fluoxetine, and they use a dose of 20 milligrams daily. There we go. Questions? Dr. Mitra.
So that was really a great overview. There's been a lot of interest over the last few years on not necessarily what are the things that are helpful. I mean, that's certainly an interest, but what are some factors in which a patient who's presenting with stroke essentially will really not respond to acute rehab? There was a huge study, a huge cohort of patients that were studied in brain injury patients, and they found that the admission motor FIM score, so having a pretty low admission motor FIM score on the acute side, those patients, no matter what you did as far as rehab, just didn't really respond. There's going to be a similar study in stroke,
Absolutely,
which is going to be published within the next 3 to 5 months. So the question for you is, what have you found? You've been doing the consults now for a couple of years, and did you come across anything in the literature?
I think it's a very difficult thing. It's not standard of care to FIM patients in the acute phase. And we can usually come up with the FIM, and we can usually kind of start to analyze and see patients and go, you know what, they're not doing this, they're not doing this. This is an obvious total FIM score of this, an obvious motor FIM score of this. I find that my gauge for patients who have done better is to at least have them at about one person assist, a maximal assist level, kind of across the board. And those patients will get better. They'll get better in a relatively succinct time, and they're more likely to be able to get home. Now, it's not to say, I think that I think what I've noticed in my reading is that there is a level B evidence for patients to come over and get the intensive therapy, may not quite make it home, may just go to skilled nursing or long-term care, but are overall higher functioning because of that intensive acute rehabilitation phase, because of that first 4 weeks of their post-stroke phase. And the folks that I've seen in the clinic, where I think the emphasis is, or the fact is, they aren't doing very well. They're not having a chance to become independent despite family members being at home. And those folks have gone from a nursing facility to another to long-term care, and that is, I think, what could potentially be detrimental. And again, this is all variable based on the actual facility. There are skilled nursing facilities out there that are emphasizing the comprehensive approach, that are finding a way to be profitable and still provide that comprehensive approach. And I say more power to them. I just don't think that's realistic for that phase, in which is just not regulated and not funded, as well as maybe inpatient rehab could be. I think that's a challenge there, and those are the patients I have a hard time with, especially in the outpatient, versus folks with very similar deficits who did well with maybe a 4-week inpatient rehab stay, skilled nursing, and transitioning home.
Yeah, just wanted to add a couple of comments to the trials that you brought up, and it really points out in some ways how very difficult it is to do well-designed rehabilitation trials. And you noted in the fluoxetine trial that they use standard and usual care. Of course, that's going to differ across sites.
Absolutely.
Multi-site study. So one of the things that was very impressive about the EXCITE trial was really the very first randomized controlled multi-site trial to actually make sure that the comparison group was the same across sites.
Absolutely.
And the AVERT trial, the early mobilization trial, took that one step further. And you can imagine that this was done in 5 different countries, and they convinced the investigators to maintain the same kinds of comparison groups and protocols. But that trial took 8 years to complete.
Yeah.
So the one point you made is that we're changing our practice with stroke units and so forth in interdisciplinary care. So over that 8-year time period, in fact, that comparison group was drifting, and the comparison group was changing as well.
Mm-hmm.
So it's kind of interesting that I think just one trial like that, you can't make a complete blanket statement yet and make clinical recommendations based on that trial alone. It does provide a warning that the first 24 hours there may be some hemodynamic instability.
Absolutely.
But that trial actually was mostly mild to moderate stroke.
Mm-hmm.
It used a relatively crude scale, modified Rankin.
Mm-hmm.
But nonetheless, it is a warning that very intense, very early rehab may, and I think you
emphasize may.
Potentially.
Yeah.
But we need more trials like this. But if they take 8 years to do, we're not going to see very many of them. So
absolutely. But that's the emphasis is being able to number one, replicate and improve some of these studies and really extending across. It's just it's a challenge, just like you said, it's a challenge, and we're challenging the way we already practice, in these patients and things that we take for granted that this is just the way it is, oftentimes. So protocols change, though. I think these trials are what's going to help us change our protocols, and both in the acute side and the rehab side.
I thought that was interesting. Study that said that obviously in the first 24 hours you shouldn't be doing therapy. Obviously we don't want to wait 2 months to start therapy, and I might have just missed it, but was there evidence in terms of the kind of the sweet spot and range that we should be getting patients up?
And that's where I've seen some other early trials or early studies that emphasize, within the 24-hour period, within the 48-hour period. Dr. Nudo, was there a study that you could quote that kind of found that there's this early, but maybe not too early?
It's really going to be a bit of conjecture at this point, but based on what is out there, I think it's something you alluded to that beyond that first 24 hours, and when people are hemodynamically stable. The dangers are probably self-limiting. People will not do a lot unless you really do something like in the EXCITE trial and you really force them to use a limb or force them to walk more than they really want to. It's going to be self-limiting to some extent. It's pretty clear from animal studies and what little human studies there are, beyond the first week to 10 days, it's clearly very safe. But there still is not really good demonstration of efficacy for this early period. And this is really the other aspect of that is dose. And of course, if you do something early in the first week, but it's low intensity, it's probably very safe. So what we don't know is how the high dose intervention interacts, but I think most people feel that beyond the first week you can be as intense as you want, and there's really no risks.
Absolutely. Yeah, hopefully that'll answer that. Yeah, I mean, that just an extension of what he said. I think that's where these studies were very inconclusive, and they maybe not the best designed studies within that 24 to 48 hours. And this is the first trial that was really controlled quite well. And so I think the one thing we can take is not necessarily when the ideal point is, but when the ideal point is not, which is that first, labile period.
A question on the console side, do you know if it's built into the order set for therapies not to start within 24 hours?
It's not built in, but these are things that are very important for us to talk about and figuring out going forth. I hate to make a new, hospital protocol based on a study. I just think we should be keeping these in mind and keeping our eyes open for new trials. And just like Dr. Mitra mentioned, the new trial coming out, kind of mimicking, actual standard protocol for rehabilitation and where patients do best with FIN scores. I think we should have those things in mind, especially as we practice. But no, I think you make a good point. Yes.
So kind of going back to the hemiplegic shoulder and these stroke patients on the inpatient side using things like Botox. I mean, I guess number one is like, what are they considering like severe, spasticity? I guess because at one point that would make me nervous. Granted, I'm not as familiar with this stuff, but are we making an already weak arm potentially weaker? What have they looked at? What does that outcome look like? And I guess the other thing with bundled payment is this something that's even feasibly like would inpatient reabuse be willing to pay for this?
It's a great question. As far as I know, this is an early trial, but a really good study, and they specifically were studying a patient population who had, quote unquote neuropathic or evidence of some neuropathic pain, but really spasticity related. So most of them were adducted, and most of them were kind of internally rotated, and so they basically just injected several rotator cuff muscles deeply, and then into the deltoid, and then into the pecs, and found those patients ended up having less pain. That was the outcome they were looking for, is less pain. So I don't want to emphasize that study too much, because it's just like you said, if somebody who's hemiplegic, spasticity is an issue. But in the same extent, you can talk about, well, when we're injecting for spasticity, are we making those patients weak in those muscles? And I mean, I think it's dose dependent. I think it depends on the patients, and I think that my goal typically is not so much, to necessarily put them at risk for weakening. It's to strengthen the opposing muscle, as well. So make sure to give them a chance to really be able to use the opposing muscle. So that triceps, which they can't really use because they're stuck here, they can now start to use that for transfers. They can start to use the wrist extensors a little bit better. And that's kind of the way I think about it. So I think anytime you start treating really aggressively and for long extent and invasively for the short term, for the acute patients, it can be a little bit dangerous. So I have to actually read up a little bit more about that study. I just didn't have a chance to read as much.
Well, thank you for a great round. And we will have a faculty meeting in about 15 minutes. See you there.